those here in person and to those online. I am Dr. Heather Strachan, and I'm past chair of the BCS Health and Care Scotland Specialist Group and the International Medical Informatics Nursing Group. And I'm pleased to introduce this year's Derek Hoy Memorial Lecture, which is now in its 12th year. It is in Derek's honour, who sadly died in 2012, that we established the Memorial Lecture. For this lecture, we invite one of Derek's colleagues, who, like Derek, is an innovative thinker and influencer, to share their thoughts and to help us shape the future and take account of Derek's legacy. I would like to mention just a few things about Derek, for those who didn't know him personally. Derek was a nurse, an informatician, an academic, and a member of the BCS Health and Care Scotland Group, and a very active and engaged member. On the lighter side, he was also a family man, a talented musician, a whisky connoisseur, and had a great sense of humour. Of most relevance to us here, he was an innovator and a visionary, and a leader and a teacher who inspired followers. And above all, he was a collaborator in the field of health informatics. Derek exemplified the importance of collaboration to ensure that expertise and relevant stakeholders informed the development of health informatics innovation. And we are delighted this year to welcome a colleague of Derek, Professor Suzanne Bakken. In this lecture, Dr. Bakken will use the framework of epistemic injustice, a wrong done to individuals in their capacity as knowers, to reflect upon the challenges posed by more recent innovations such as chatboxes, generative AI, predictive models, and phenotyping algorithms. She will also use examples of her programme of research to illustrate mitigating strategies to address epistemic justice. Like Derek, Suzanne is pretty awesome. She's currently the Vice Dean of Research and Professor of Nursing and Professor of Biomedical, Alumni Professor of Nursing and Biomedical Informatics at Columbia University. She received her Bachelor's of Nursing from Arizona State University and MS from the University of California. Following her doctorate in nursing at the University of California, San Francisco, she completed a postdoctorate fellowship in medical informatics at Stanford University. Prior to her current position at Columbia University, Dr. Bakken held a tenured faculty position in the Department of Community Health Systems at the University of California, San Francisco. Her program of research has focused on the intersection of informatics and health equity for more than 30 years. She leads the Centre of Community Engaged Health Informatics and Data Science and co-directs Reducing Health Disparity through Informatics pre- and postdoctorate training programs. Dr. Bakken has published over 300 peer-reviewed articles and received many awards, including the Friends of the National Institute of Nursing Research Pathfinder Award, Sigma Theta Tau International Nursing Research Hall of Fame, American Medical Informatics Association Virginia Saba Award, and American College of Medical Informatics Morris F. Collin Award. And most recently, and very exciting, she was honoured as a living legend of the American Academy of Nursing. So it's wonderful to know a living legend. Dr. Bakken currently serves as editor-in-chief of the Journal of American Medical Informatics Association and is a member of the Patient-Centered Outcomes Research Methodological Committee. She is a fellow of the American Academy of Nursing, American College of Medical Informatics, and a member of the National Academy of Medicine. So, truly an awesome person. So, welcome and thank you very much for coming to give this year's lecture, Suzanne.
Thank you so much, Heather, for that kind introduction. And I'm honored and humbled to be here to give this lecture, and especially with having Derek's wife with us today. And I think I will start out with I first met Derek in 1991, and so I knew him for more than 20 years, and I have told a couple of stories about him, but I'll share a musical one since it comes to such a musical family. And we were teaching in the Summer School of Nursing Informatics in Coleraine in Northern Ireland, and he had connected with another musician. And so 3 men from the Netherlands, plus Derek and Alan Hislop and I all got tightly squeezed into a car like sardines, and went off to a pub outside of Coleraine, and it was like being in a movie. It was just magical for me coming from the US to just see the band come together and the waitresses coming in with the beer and starting to dance a little jig and stuff. And so it was such a special musical memory. And I'll mention some other things, but more from his perspective as a scholar. And so I thank very much the British Computer Society for inviting me to share some reflections for you today. And so in terms of objectives for the talk, I want to describe the framework of epistemic injustice. And epistemic injustice is a wrong done to individuals in their capacity as a knower. I want to reflect upon some of the challenges faced by new health informatics innovations, such as chatbots, generative AI, predictive models, and also phenotyping algorithms. And then I want to illustrate some of these mitigating strategies through a few of my projects. And then I also want to mention about some of that, how I try to take that forward by translating it into policy. And so when I thought back about Derek and really how he exemplified the importance of collaboration to ensure the expertise of relevant stakeholders to inform the development of health informatics innovations. And I pulled out a couple of his papers, both thinking about the tool that he designed to help with collaboration with the ICNP. And then another project was really focused on the collaboration of a variety of stakeholders around developing clinical templates as a national project. In his work, and part of the way I knew him was not only through the summer school, but also doing work in nursing terminology. And we have, I can only find one co-authored paper. It felt like maybe there was more. But this was one that we did with Nick Hardiger, who's also in the room here today. And it was talking specifically about formal terminology systems, which is really taking the expertise of nursing and the terms they use and turning it into something that can be computed and used for decision support and other processes. And as I was looking back and reading this particular paper again, and I pulled out a couple of phrases that I felt really illustrated the importance of engaging knowers. One is developing appropriate consensus building tools and techniques. Also talking about the importance of dialogue models for those interactions with the users of the terminology. And also really an important notion of having a contract with the users. So and the notion between having a contract between the reference terminology developers and those who would be using it. And so that things do end up being used for the purpose they were intended to do. But I'm going to talk just a little bit definition slide, and this may not be, I don't know if this is an issue in the UK. In the US, there's always a lot of conversation. Is it data science? Is it machine learning? Is it artificial intelligence? Is it informatics? These are all computational fields that we're working in. One of the simple ways I like to think about it is displayed in this particular diagram. And we think about what is it we're processing. Are we processing numbers as data? Are we processing text as data? Are we processing images as data? And this particular diagram really looks at everything flowing into artificial intelligence. And when I first started using this slide in 2021 with one of my postdocs, Caitlin Dreisbach, what I used to say was one of the things how I distinguish informatics is a bigger human component in it. It's just not about what the data are you processing, you're thinking about how it's going to be used in practice and policy. But now one of the things we see, it's becoming more prominent to think about human-centered AI, keeping the human in the loop. And so I don't think it's important what you call it, where I come at it from my perspective. It's very important that the nursing voice is in the mix and that nurses feel empowered to bring their expertise into the conversation. So now talking about epistemic injustice. Epistemic injustice is a wrong done to someone in their capacity of a knower. And this came out of a 2007 book done by Miranda Fricker, who is actually a British philosopher. And today I discovered she actually works at New York University, so now a few miles away from my work, so I think I need to contact her and tell her how much her thoughts have really influenced me. But when she talks about this notion, she talks about it in two different ways. One is testimonial injustice, and that's when prejudice causes a hearer to give a deflated sense of credibility to a speaker's word. And this can happen at the individual level of the structure of prejudice. So I'm going to give you an example in my life. I would think of testimonial injustice, and I'll speak from my experience as a mother, taking a child in to see a clinician, and the clinician said, "You're worrying too much. That's normal." And as the mother, I say, that may be normal for somebody's other child. This is not normal for my child. So I'm asking people online and in the room to raise your hand, physically or electronically, if you've ever had an experience in which you feel you've encountered testimonial injustice, where people gave a deflated sense of credibility of your words. Yes, it's all of us. It does end up being all of us. So that's one of the flavors of epistemic injustice. The other is the notion of hermeneutical injustice or interpretive injustice. And basically, it's a situation in which, because of the lack of interpreted resources, it puts some at an unfair disadvantage. And so one of the ways this can play out clinically is, as a clinician, you can say, well, why didn't the patient tell me that? That was important to what was in my mind, but it wasn't, the patient didn't have the mental model that allowed them to think that this was the piece of information you're looking for. So either in your experience as a clinician or in your experience as a patient, how many people have experienced this kind of thing? At least me. So we're getting some nodding heads and some up. And so we really end up with the situation of having a lack of common ground. And this has been studied, epistemic injustice has been studied first in the general health literature, and first thinking about it from the perspective of just the patient role. You're fine, you can be quite expert, all of a sudden you're sick, you may be hospitalized, and suddenly your statements may not be taken as credible. A lot of the research in healthcare has been focused around mental illness, and when someone has a mental illness, whether or not their subjective impression should matter. A lot in terms of the pain experience, and we knew this has been a major thing when you see the difference between the subjective symptoms of the patient and maybe an objective measure, those types of things. And recently, there's also been a lot of work done in thinking about north-south collaborations. And this could be thinking of a global, and it would be expressed as really diminishing the value of the local knowledge and really emphasizing the importance of the generalizable Western way of thinking. But more recently, I've heard this come up in the US, and just when we think about working with our communities. And you might have your great study design, and then you have the findings, and no one can implement it. And so I've heard much more of just like, how do we end up navigating that generalizable knowledge versus what might be the really important local knowledge to really make something work. And how this gets often expressed in things that may matter in the academic world is where you are in the authorship list. And often when you think about these community collaborations or these North-South collaborations, the local knower is often right in the middle of the pack, never the lead, never the most senior kind of thing. And so we have to think about how this plays out. And I'm working with African colleagues on a workshop that we're doing and next year that's really focused on how does epistemic justice in the African data science context. One of the things, and that's been generally in healthcare, but one of the things that also we have to think about is the recent health informatics innovations that have their potential to perpetuate epistemic injustice. So we think about things like chatbots, we think about things such as generative AI, we think about things such as predictive algorithms, and we think about things such as phenotyping. One of the things that they all have in common is missing voices. So when we think about it also from the perspective of knowers, whose data is in that database that the algorithm is being trained on, and how can we expect it to be generalizable if we have many missing voices? And so that's really important across all different types of innovations. But when we think about things such as predictive algorithms, and to a certain extent some of the categorization by phenotyping algorithms, and that is really pulling different sources of data and making a classification about someone in a way that may influence their care. Where I think it's critically important for nursing is when we think about this in context of care. One of the people who writes brilliantly about this is Georgia Posey. She has a number of papers that have been very influential in my thinking, and she's a Dutch, I think still a PhD student. But one of the things that she brings up, and I think it's critically important for thinking about it in the nursing context, is sometimes those predictions or those output of a phenotyping algorithm becomes the gold standard. And so how does that really work? And I know one of the things you're struggling with in the US, and my impression would be it would be a struggle for you all in practice as well, is how do clinicians integrate these things into care without diminishing the expertise of the clinical judgment and the experience of the patient? And so it really has to be a triad. And we can't have a situation in which the algorithm becomes the gold standard. It's another piece of information that needs to go into the conversation. Luckily, although we haven't so much thought about it from the perspective of epistemic injustice, I think there are a number of strategies that we've used in health informatics that can be thought of as being able to mitigate epistemic injustice. And so thinking about human-centered design, thinking about citizen science approaches and which problem to study and some of the solutions are worked out by the people that are influenced by the output. Thinking about how to integrate patient knowledge work into ways of knowing. Thinking about different types of data sources, because so much of these algorithms are trained on textual data, and then you think about populations you might work with who may have more of an oral tradition, or they don't have a huge volume of text to help with the training. And we also have technologies that help promote access to data sources. And so we think about something that's very common in the US now is open notes, in which the clinician's notes are available to the patient to review. And I always check about how the clinicians describe me when I'm reading my open note, and whether I'm looking whether I'm looking age appropriate, or am I looking old for my age or young for my age. I'm just curious about these kind of descriptions, and checking how they describe my mentation, for example, and whether or not I'm a good historian. But we also think about different types of tools, and this is where much of my work is focused on tools that would increase the capacity for comprehension, analysis, and interpretation of data and information. And so that's the theory. We're going to move into some examples now, and I know that's a lot to start out, but I want to use 3 examples of collaborative health informatics research that my collaborators and I have done through the decades, that have been viewed specifically through the lens of epistemic justice. And the first one I want to start out with is one of my first examples with working in our local community. And Columbia University Medical Center, including our School of Nursing, are located in Washington Heights. And this is a very, it's always been a vibrant immigrant community. The immigrants have changed through the years. It started out being quite Irish, but now it's predominantly Latino. And we wanted to study some barriers, enablers, and incentives for research participation. So I was one of the leaders of the study. And so after we collected our data, talking to community members, community clinicians, community leaders, I really came out of it with the notion that when we think about the findings of research, we need to disseminate it in at least four ways. Of course, we have the scientific publication, but we need to do a publication, or we need a messaging that would apply to the clinicians in the community. We also need to think about what might be relevant for the policymakers so they can advocate on behalf of their constituents. And lastly, the people that live in the community, as well as the study participants, need to get information back in a way that is culturally congruent and health literate. And so because of that, as I became involved and then the leader of a large project that was called the Washington Heights Inwood Informatics Infrastructure for Comparative Effectiveness Research, I ended up integrating some of these notions. So the basic idea behind this study was to take all the different data sources that exist for an individual, inpatient, outpatient, what might be in more administrative records, to bring them together into a research data warehouse, make a browser, which we called REDX, or Research Data Explorer, so that clinicians could access the data. And the idea was that then the clinicians could improve the health of the community. The big thing that I added to the project, which was missing in its initial conceptualization, was to add the box that says community members. And what I wanted to do was to give the community members back the data that they had helped to generate. And we had collected data on almost 6,000 Latinos in the community. And so what we knew going into it was the goal of being able to have whatever information we provided, we wanted to be comprehended. We wanted people to be able to act on it for self-management and communication with healthcare providers. It needed to be useful for individuals with varying level of health literacy, and it needed to be in English and Spanish because the majority of our data collection was done in Spanish. And in terms of health literacy by both a subjective measure and an objective measure of health literacy, the majority of our sample had inadequate health literacy, so that we knew we had to really think about visual communication, meaning conveyance of ideas and information that forms can be seen. And so the approach that we took was a creation of infographics and a tool to tailor them, in this instance individually, as a resource to mitigate hermeneutical injustice and return the research results to the community members. And then as far as looking at it from the perspective of testimonial injustice, we did human-centered participatory design, and that was our way of incorporating the community members' lived experience. And now I'm going to just show you some pictures. This is a measure of fatigue, which feeling run down was considered to be, from the lived experience, a better descriptor of it. And in this particular thing, we worked with a number of different designs. The battery metaphor ended up working well. And in this instance, it was showing an individual's results compared to other people in their age group. We also wanted to show overall health. This type of display is called it's an icon array, and in general these did not work well for us, but the stars seem to work well, and once again we're providing somebody's self-rating of themselves against other women in the group. We tried this to do fruit consumption and never could get it right, because the people in our community, if we put an individual fruit, they took it literally. Okay, this is how many apples. And then we tried a fruit basket. And one comment in our qualitative data was, all that fruit and the pineapple too is the idea of the, and so that's why it's very important to work with the community. This was a complicated measure called the patient promise system. Anyway, it's a set of standardized measures that are somewhat difficult to understand. But one of the things that's worked well for us through a number of different projects is being able to put things on a number line with colors and going the green and red colors. But there are other hints here as well, also having the words better, average, worse, and telling someone their actual symptom score here. So multiple cues to help people understand. This is an example of a more objective measure, body mass index, but you see similar kind of cues as far as we see the colors, we see their particular measurement. This we add a definition, and then we put their measurement on the symbol of the body to help with interpretation. In this particular one, we wanted to show a variety of measures with different denominators to give people an idea of their overall health. So we went through multiple iterations with this, probably at least 10. And the way we did our participatory design, we would bring a series of pictures into the participatory design group, and then people could look at them, they could draw on them, they could do different things. But one of the things that's very hard for people to do is to kind of discern a proportion in the absence of having something to compare it to. So we found what made this work was having the dotted lines around the value, and then actually showing them what something would look like if it was completely fleshed out. So in this particular project, we did, I think, 18 participatory design sessions over 100 people. So we did many, many iterations. It was the first time we did it, and so we didn't do it as efficiently as we're able to do it today. One of our most complex things we were trying to convey was really this one, and it was around blood pressure. And I said that WISER stood for Washington Heights Inwood Comparative Effectiveness Research. And the focus of the comparative stuff, the comparative interventions, was really management of hypertension. So we really needed to get the measurement of blood pressure right. And so we started with doing a stoplight metaphor. Everyone understood it, but a lot of people didn't like it. And we ended up with this more complex one because a member of our team said, but why should they care about blood pressure? And so in this, we have one of the ways the blood pressure is taken. We also, you see that number line again where the blood pressure is displayed, same kind of notion of the colors. But we added this risk of high blood pressure. And so additional cues we see in this is we see a common word and then we have the professional word underneath it because we felt it was important that people have both some common words to understand it, but that some of their clinicians would be interested, might be speaking to them with the formal words. And this is something that has been taken forward in a number of clinical studies. It's been used in a post-stroke study and has been useful as part of an intervention to prevent additional strokes. It's also used by United Healthcare in their patient glossary. But importantly, we were returning data to 6,000 people. We needed to, and we're informaticians, so we had to come up with a way to tailor it because I'm showing you those pictures, and there are some things that are steady there, but there are other moving pieces, such as the diastolic and the systolic blood pressure, somebody's symptom score, et cetera. So we came up with the notion of a tool that would help us to tailor that. Then for the next decade, we continued to do this kind of work and continued to refine our methods. We learned that there was a number of fields that actually influenced what we were doing. And so I told you the first time we did about 18 or 20 participatory design sessions. Now we do that much more efficiently. But anyway, we continue to work in other areas, including dementia caregiving. And we had the notion of being able to pull everything together into a toolbox. And we're having it because we wanted other people to be able to do something similar and take advantage of our hard knocks that we'd learned through doing it sometimes wrong. And we weren't having much luck with that. And then the opportunity actually came with COVID. And the US put a lot of investment into something called RADx UP, or Rapid Acceleration of Diagnostics for Underserved Populations. And while most of the RADx UP projects were around initially the distribution, making sure people got tested, later on around the distribution of the vaccine, they had some projects that they called SEBI projects, which stood for social, ethical, and behavioral implications. And so our ethical argument was a very simple one. We simply said, it's unethical to give people information they can't understand because they can't act on it. So that was the basic premise. So what we proposed was a toolbox, which for short we called the ReadyViz toolbox, where we pull together some of the computational stuff as well as the documentation and do some new designs specifically for COVID. We imagined a variety of users. As it turned out in New York City, much of the COVID response was very community-based. So as our project rolled out, we ended up focusing primarily on the community use case. And so you can see our goals here. We wanted to reduce disparities through culturally congruent, health literate infographics, and we wanted to support comprehension, decision-making, and motivate appropriate behaviors. Thinking about collaboration, which of course was so important to how Derek worked. We had our team at Columbia, but we partnered with somebody we partnered before in Harlem, the Association to Benefit Children. Initially, our work was only in English and Spanish. When we had the opportunity to get more money to focus on vaccination, and so we added 2 other health disparate groups in New York City, and those were Bangla speakers and and Chinese immigrants. So we ended up data collecting in 5 languages because we did both Cantonese and Mandarin, but when we created the infographics for Chinese, we did them in simplified Chinese. So we did the project through 3 phases. We did, because we wanted to do testimonial injustice, we had a required common data element questionnaire that all the projects collected. You can see what some of the items we're looking at there. But we also did focus groups and interviews to try to get more from the local knowers. And this specifically focused on experience and beliefs about COVID-19 testing and vaccines, thinking about trusted sources of information. We had almost 900 participants. You can see some of the breakdown here. I told you why we were doing the study in the way that we were doing it, the different populations. One of the things I want to specifically point out is 34% of the people answered the numeracy question incorrectly, and you see it there. Which number represents the biggest risk of getting a disease? So think about COVID, it's not that long ago, it's still around, but you think about what's your chance of getting COVID, what's your chance of getting a side effect, and you have a third of our population that weren't able to tell the difference between these 2 numbers. And so there's some implications in working with that. Interestingly, when I first showed this, I was disseminating our research findings in the Harlem community. There was someone there who's Chinese, and she said, it's not going to be true of the Chinese. Well, actually it was. And we had much smaller numbers for them, so it didn't matter which of the groups you came from. There was an issue with literacy. These are the things that people worried about. These are motivators and concerns. I'm sure they were very similar here. Trusted sources of information. The most trusted source, thankfully, was a healthcare provider, and the least trusted was the social media contacts. But you see a lot of government kind of things that end up being in the middle, including the U.S. Coronavirus Task Force, although Tony Fauci came out as very trusted and mentioned in the qualitative data. So we had that quantitative stuff, but when we went out to the focus groups, what additional things did we learn? Well, some things just reinforced some things we could tell from the survey. There was a misunderstanding about how the vaccine works. People were really, really worried about how fast it was developed. A thing that we didn't have any survey items for was really about long-term effects for self and offspring. And we were really, going into this, we assumed there would be cultural difference between the Black participants and the Hispanic participants. But even when we added the other groups as well, it really was age that seemed to make the difference. The old people weren't worried about the long-term effects. They were more worried about dying for COVID, and people in childbearing. This is really a big barrier, very worried about long-term effects for themselves and the offspring. A little bit of conflict with religious beliefs. One of the other issues was in the way the data were shared, people just didn't see themselves in the data. So yes, on average, but where's the data for an 80-year-old Black woman? That's what I want to see before I'm going to get the vaccine. And something that came out very strongly only with our work with the Black participants, because of much of the history in our country, was the way it happened in our situation was the vaccine was rolled out to communities of color first because they were having the highest mortality rates. But it did make people worry about racist intentions. Are we the guinea pigs? White people usually get everything first. And so they felt like the white people would get the real vaccine. And when I was sharing this in some of my dissemination, and a woman in the audience explained a little bit more about it, she said, when they came into our housing development, they gave us one mask, one bottle of hand sanitizer, just a few things, a bottle of wipes or something for the household. And she said, when they came in for vaccine, they had a vaccine for everyone. So who wouldn't get a little bit suspicious? So it was very important that this is really an example of really trying to get the input of different knowers. So how we took this forward into our infographic designs, the content should describe different types of tests, vaccine mechanisms, key hesitancy concerns of a variety of populations. It was important because of who would be trusted to allow branding from trusted source in the community, support cultural congruence, and we had to have some options for communicating risks and proportions since a third of the people were bad at literacy. So when we do participatory design, we do it in 2 stages. We do broad and shallow. We usually do a survey of about 100 people that we just look at some icons we might use. And then we go into the smaller participatory design. Initially, we workshopped 2 designs, a more traditional textbook design and a personified design. I was a little worried about personified because of it being a little cartoony and COVID was serious, but there was a very clear winner early on, so we went with personified. And it's important when you're doing this kind of thing that you have a conceptual metaphor, and our conceptual metaphor was really war. So you see a lot of things related to that. So you can see that our antibodies, they have, there's lightsabers and some other tools that are in there. But basically, you can see we put it into 3 different parts: how the vaccine makes you sick, how the vaccine works, and then how we dealt with, and so the text is editable, the pictures are editable, and then how we dealt with the needs of specific populations. Some of the things I mentioned, you can see we've turned them into the questions. So when people use the tool, everyone gets that standard part that I just showed you, and then they can choose 3 additional questions that then that gets put together for the information that they get. And then we turn that into the toolbox itself. And so what happens is you have a catalog of infographics. It's a web-based tool, and then you can edit it in the various ways that you want it to use it with your clients. We changed the name from ReadyViz to TaylorViz because there is a tool used in the US that's not a visualization tool, but it's called the ReadyViz toolkit. So we're worried about copyright infringement. And so we've taken this forward into another project, and that is the All of Us Precision Medicine project. And this particular project, and this is a very expensive project in the US, where people contribute genetic data, electronic health record data, survey data. And then this project was really about returning value to community from the toolbox. So before we got involved, one of the ways that the public interacted with this was to do these data sandbox activities where they do a treasure hunt. They'd find out information. And then subsequently, the vision was after they found information in the data sandbox, they would be able to create a tool that they could use in their community-based organization. So those are just some of the ways that the epistemic justice has played out in some of the mitigating strategies. I'm taking it forward in 2 ways, thinking about it in terms of a policy. We have a work group at the National Institutes of Health that's called Public Engagement in Clinical Research. And I am the co-chair of this 2-year working group, and you can see the pictures of our participants. But we're charged with coming up with a framework and a toolkit for facilitating research across public partners in research across the stages of the research life cycle. Additionally, one of the things that Dr. Strachan mentioned about me was I'm the editor-in-chief of a journal. And the journal this is in its 30th year. It's in my 6th year as editor-in-chief. And I decided it was time for a new goal. And so this new additional goal for the journal. So you can see we want to exemplify best practices in publishing to advance health equity and justice. And if you can see in part C on this slide, it's innovative, rigorous, transparent, quantitative and qualitative research methods that address fairness and mitigate epistemic injustice. And then in concluding, looking at collaboration for health informatics innovation through the lens of epistemic injustice suggests the needs to really broaden the diversity of input inclusive of lived experience in the creation and implementation of data sets, algorithms, digital health interventions, develop strategies and tools that facilitate stakeholder determination, prioritization of health-related needs and resources to meet those needs. Really think about how do we facilitate stakeholder capacity for co-production, translation, and dissemination of data, information, and knowledge. And then also on the policy side, how do we apply policy frameworks? And with that, I will just acknowledge the various funding, but also the important knowers who have contributed to the projects that I have shared with you. So thank you very much for your time and attention.
That was really fascinating, and I hope you are able to take some questions, Suzanne.
Yes, please. That's the best part.
I was just thinking of all the sort of projects and design projects I've been involved in, and how some of that could be applied. It's really, really important going forward, and we need to do so much more. So we can take questions from people online. I think if they utilize the tools to type in, is that right? But we can also take some questions in the room. So maybe while people are thinking of questions, do we have any questions in the room from people, please? Right, let me give you the microphone. Thanks, Nick.
Thanks, that's really fascinating. And I think, I suppose my question, I don't particularly like it when people say it's more a comment than a question. But
I don't mind.
I'm going to say it, but I would like your reflections on it. So justice, I'm thinking about the word justice and the concept justice. You've used it a lot, and a lot of your work has been about equity, about fairness, and I think it's a good goal in itself. But there are other three classic ethical dimensions associated with health, which is beneficence, non-malfeasance, and autonomy. And I think the work that you're doing is going beyond justice. Justice in itself is really important. It's ethically the right thing to do. There's a moral imperative. But also, what we're talking about is valuable knowledge, evidence that's being missed potentially, or disregarded, or minimised. And I think kind of there's more to it than it's just the right thing to do. It's actually potentially harmful or benevolent to people, or beneficial to people. So yeah, I was just wondering on your reflections, because I think by a focus on justice, of course it's great and it's the right thing to do, but it's kind of downplaying the validity of other aspects, the other ethical dimensions, so the validity of knowledge as evidence coming from the first person.
Yes, and I've thought about it a couple of different ways. And so one of the things, our work is always contextual. I should say our work should always be contextual. It's not always. Some people seem to operate in a vacuum. And one of the things that has happened in the US in recent years is really the movement from, at first we were talking about disparities, counting them. Then we got moved to really focusing on health equity. And then people thought more broadly about justice being bigger than any of those. And so when you tie it back to the four, principles from the, going back for decades, one of the things I've talked about often is what I've thought about and talked about is, are those four principles enough? Are those pro-ethical? And I think this fits into a number of them, both in thinking about from the autonomy perspective, but also thinking about things like beneficence, that we will fail to get the full benefit from the research. And certainly in the activities that we're doing at the National Institutes of Health, which is evolving and putting effort into making this happen through its volunteers, it is the notion that research will be better if we do engagement. This is absolutely not about making sure you have enough participants in your clinical trial so you have adequate power to answer this question. This is really thinking about a broader way to do research and across the life cycle. And the other thing that really comes through in this and is reflected in our Engage working group is it's not transactional. It's really not transactional for a particular purpose. You really, when you're thinking about the public and particularly about the community, it has to be a relationship and trust that's built across projects. So it's much bigger than, I'm doing a study, do you want to provide input on how I can make XYZ better or to help with the recruitment? It really is much bigger and not transactional. So I probably not answered your question, but I'm just saying this is how I'm thinking about things these days in my own work and in my own interactions with community and with the opportunity I have both as a journal editor and as the co-chair of an important work group at the NIH to try to influence things at a couple of different levels.
Thank you, Katie. Do we have any online questions coming through?
Thank you. Firstly, thank you so much for your talk and for coming over to speak to us, and to Heather and Sharon for organising that you could speak at the Derek Coy Memorial Lecture, with Christine here as well. I'm interested in, as distinguished international academic and informatician, which communities have you most enjoyed working with, or which countries do you feel you've made a big difference in, that you're really proud of and stay with you?
Yeah, and this is, it's quite interesting, the notion of a community. And I've worked on things that are, and some of the ways people define community, it can be a geographic community. People talk about a virtual community, but what's kind of common in most definitions is the notion of some shared values and things like that. And so who your community is going to be is going to depend on who the nature of your project. And so in some instances, it may be that you're doing something in a geographic community, and so you'll think about the residents and the policymakers and that kind of thing. In other instances, your community can be your nurses in the hospital. I'm had the opportunity to, I'm part of the African Public Health Research training through data science initiative, which is between Columbia University and Addis Ababa University and the University of Nairobi. And so we're really fleshing out what this means in the East African context. And I think we have so much to learn. And Dr. Hardiger and I were both at a workshop that was more about ethics of AI in nursing a few years back. And I was really inspired by that. And when I started working with the Africans, I said, we need to go for this funding. And in this instance, we went with this framework and are fleshing that out. So I think there's lots of opportunities to work with different communities, and I think the principles end up, I have some water, Heather, already. I think the principles remain the same, and how I really push this, particularly with nurses who are not informaticians, is saying, you have very, very important expertise. You don't have to know about the technology, but you need to value what you're bringing to the table.
Right, we have a couple of minutes. Are you okay to continue?
Yeah, I mean,
I can give you...
I don't know what. Well, maybe my throat is wanting Diet Coke.
I'll add my thanks to you coming all this way over the ocean to present. One of my questions is how to measure success and isolate what you're doing from these people have benefited from this work because it's kind and compassionate and you're presenting information in a way they can understand. And also the continuity aspect, that they're actually involved in a project. How would you be able to work out this is a success because of our health literacy approach, or this is a success because we've labelled it as injustice? There's so many different things. It's kind of like in the basket of preventative medicine, isn't it?
Yes, it is. You're so right, Christine, in that question. And I think about it often from the perspective of what part of the whole thing do I do as an informatician? And so when we think about these infographics that we've developed and building the tools, and we can take that epistemic justice framework and implement it in our part of the puzzle. But we make sure there's things to hand off, but we also work with public health and clinical researchers who will design a study that will then take some of these things forward. But one of the things we are very much, and so that's like in the day-to-day life, it takes a team, people who are informaticians and can do some of these things, people who are experts in implementation science, people who do different types of thing. Not everyone needs to do the same thing, but if you come at it from a common framework, then your question was also about measurement and how do we know it's successful. So in some of these things, we can measure it in a particular study, but this is actually one of the issues that our committee, our working group at the NIH is discussing in our work, and really coming up with some of those measurements of success, like have you adequately engaged. And so we don't have a lot of I would be able to say a lot more a year from now because our work will be done, but there are some very interesting ideas being proposed to think about how would we measure adequacy of public engagement.
Okay, I think we need to let your voice rest now.
Diet Coke did the trick.
Good. It really remains for me just to thank everybody here for coming. I'm sure, like me, you will have really enjoyed Suzanne's talk, and I've got lots of thoughts to share with you on the journey home. I'd like to thank people online who have joined us and those that will watch the video in the future. I'd like to thank Alan for his amazing work in recording this, and the venue as well. But most of all, I would like to thank the awesome Suzanne Bakken. Thank you very much for coming, and thank you, everyone.
My great pleasure.